Hello, my name is John Kirk. I'm a happily retired former healthcare executive and a former member of the board for over 10 years of the California Association of Physician Groups, the predecessor organization to APG. We have a very interesting program for you. We're going to be interviewing and hearing from Mr. Stephen Sell, who has recently risen to the position of being CEO and a board member of agilon. Prior to that time, Steve was a senior executive with HealthNet, rising to the position of CEO, chairman, and president, I guess, of HealthNet, which is the largest single division of Centene. It's an honor for me to interview him and to introduce him to you. Educated at Swarthmore and with an MBA from Stanford. Ladies and gentlemen, here's Steve Sell.
Thanks, John. It's great to be here and really excited to talk to you about transforming primary care and being part of this summit. Agilon Health is a company that was really built around the idea that the current model for primary care that's based on a fee-for-service system is woefully broken. And so we're a 6-year-old company, and we've really built a new primary care model that allows primary care physicians to practice medicine the way they were trained and take the total responsibility for cost, quality, and experience for their patients. We do that in a really unique way, John. We partner with existing physician groups, people who've been in their communities for decades and are extremely well respected. And what we do is we transition the doctors, the senior patients, and the payers from a transactional fee-for-service world into a holistic total care world in which that primary care physician has that total responsibility. We launched our first partnership. We implemented in 2017. We went live in 2018. And we've recently announced groups that we're bringing on board for 2023. And when you look at the numbers on this page, you can see how great the need is out there for a new primary care model. Next year, we'll be approaching 500,000 senior risk members on our platform. We'll have just over 1% of the primary care physicians in the country in partnership with us. And primary care physicians in virtually every type of group in the country now are in a partnership with agilon. We started with primary care only groups, but as you can see in the lower right, we've added multi-specialties, we've added IPAs, and we've just announced our first health system that'll be coming on board for 2023. And so that's given us an incredible geographic expanse, 12 states and 25 communities. You know, the backdrop to this is we really felt like we needed a scaled solution because this is a really scaled problem. It's a demographic issue. All of our practice partners have a mix of commercial and senior patients, and senior patients are becoming a larger and larger part of their practice with the aging population, 10,000 people a day turning age 65. And that's really pressuring them economically, where they typically are making money on their commercial population, but under a fee-for-service population, incredibly challenged for Medicare that might be paying them $100 or $200 a visit. At the same time, primary care physician capacity is incredibly strained. Physicians are burning out. To make the economics work, they're having to see more patients at a time that they should be seeing fewer patients and spending more time with their most complex senior patients. And there's incredible variation in terms of the populations that are being served and the outcomes that are being delivered. The picture on the right is sort of the way that as we went around the country and talked with so many primary care groups, we saw things playing out. Over time, absent a new primary care model, more PCPs were going to be leaving practice, the economics were going to be getting more challenging, and the problems would just exacerbate. That's where we came in. We said, hey, we really need a new business model. And our goal is really to move people from the picture on the left to the picture on the right, from a transactional per visit world in which the economics are really not sustainable. There's not enough time. There's not enough coordination across a senior patient that might be seeing multiple specialists. And with multiple health plans and with Medicare fee-for-service, there are different incentive programs, different quality mechanisms that are being used. And so it's a very fragmented experience. With this holistic total care model based on capitation, these primary care physicians are now in a position to manage the totality of the health, both in the primary care office and outside of it. We bring incredible care team resources, social workers, pharmacists, care managers. We embed people in the ERs, et cetera. And one of the most important things is we might work with 3 to 5 health plans in a community. There's a single experience. The health plans agree to not have a different incentive program, but all of it is around this total care model and driven by that one single approach. The way we got here, people ask us what's different. We made some very clear strategic choices to really drive this. First off is we're partnering with existing physician organizations who've been in their communities for decades. We're working with existing doctors, using existing facilities, existing payer relationships. Second, we target non-traditional geographies. You won't find us in Southern California or Southern Florida. You'll find us in markets that have been 100% fee for service and are making the move for the first time. And then third is we exclusively focus on the complexity of the over 65 patient, and we exclusively focus on moving that group and the physicians and the patients into that full risk relationship that I talked about. It brings really important advantages for those patients, for those partners, alignment, scale, and first mover, and I'll just walk you through those real quickly. An aligned physician really behaves differently. One whose practice economics are aligned with better cost, quality, and experience outcomes will behave differently. And we've seen that and again. We give you a few examples on this page. An aligned physician is much more likely to refer to a high-value cardiologist. Someone, when we look at the data from a quality perspective and from a cost perspective, is really at that top end, and you're able to save $2,000 per patient. In all of our markets, prescription drugs, major cost for the Medicare population, the ability to substitute one drug for another that's clinically equivalent, to get that primary care physician or downstream a specialist to make those changes is really meaningful. Scale is a key part of it. So alignment's number one, scale is another one. We have 1% of PCPs nationally, but within these markets, by going there and partnering with groups who've been there for decades, we're able to start with meaningful scale in terms of adult primary care capacity. As we move primary care from the bottom of the pole to the top in terms of their overall importance and have scale, we can really influence specialty costs and facility costs where most of the overall expenses occur. And when you put those two together, alignment and scale, our primary care physician partners are changing care delivery in their communities. They're moving from the picture on the left to the picture on the right, moving from an uncoordinated, complex world in which when the patient leaves the primary care office, that primary care physician really doesn't know what happens with them. If they go to the ER, they go to the hospital. To the world on the right in which there are care team resources in the office, they have more time in that visit, but there's also care team resources at those critical places in healthcare, in the ER, doing the discharge planning at the hospital. We have centralized referral teams that make sure that patients get to those top quality specialists that I talked about. And as I said, we go to communities in which they've been 100% fee for service. They're really diverse. And so they're smaller communities, smaller groups, larger groups. Interestingly enough, we're in many markets in which PPO is the dominant product, 60, 70, 80% of the product mix. And we work with a variety of EMRs. And so what we like to say is literally any group in the country that's thinking about making a move has a reference point in some of these 23 groups I talked about at the beginning that looks like them and sounds like them. All of that yields to we're really improving healthcare quality and experience overall. You can see the net promoter scores of 80 plus, which is better than Apple and Southwest Airlines. You can see in terms of the admits per 1,000 and the improvement in cancer screenings and annual wellness visits. And all of that is based on a really tight patient-physician relationship. Our physicians have been in our practices for an average of 11 years. And the patient-physician relationship is so tight that nearly 90% of those patients rely on their physician for the referral to the specialist, even in a PPO world. All that leads me to transforming healthcare as a social imperative. We believe that our purpose is really around empowering physicians to transform healthcare in their communities. In the next couple of weeks, we'll release our ESG report that we're really proud of. We're having a meaningful impact in terms of transforming healthcare at the local level. I want to end with one program, John, and then go to Q&A. We're really proud of what we're able to do in our work with women physicians and the work of our Women Physicians Leadership Council. Turnover in primary care, people leaving primary care is a real challenge for us, but women physicians are leaving at a much higher rate than their male counterparts. That is really a challenge of a fee-for-service transactional world in which people have to run faster and see more patients. What we found is not only do women physicians have better outcomes, but particularly in value. They're exceptional in terms of coordinating, being a team-based person, and having exceptional relationships with their physicians. And so we look to grow our women physician base. We look to bring back some of the women physicians who've left adult primary care. And we believe this is something that's going to be great for the communities, great for our partners, and great for senior patients. So with that, John, we'll go to questions with you.
Well, Steve, thank you very much for that excellent overview of your company and for the explanation of the model. That's the good news. The bad news is that we have burned up about 14 of our available 30 minutes. So I'm going to do this in a hammer-on fashion and ask you to be as succinct as possible as you come, because I do have some questions for you and some things I'd like to get you to react. The first of these concerns the ongoing debate, of which I believe you're aware, over the future of Medicare Advantage, given Dr. Berwick and Dr. Gilfillian's mortar shell of an article recently that has created such a stir, in which they basically say that upcoding and overcoding by primarily corporate members of the provider community has resulted in a situation in which MA is actually more expensive to the taxpayer. I'm obviously oversimplifying, but they end by recommending that the program be abolished and we move to a more ACO-centered kind of incentive program. Could you tell me, just two-part question very quickly? One, are they on track? Is this a real problem, or is it a made-up thing in the academic world on the first one? And secondly, if so, what are your thoughts on the proposed solution of just doing away with the program?
Well, I don't think doing away with the program makes sense at all, John. I think that, I would start with, I think the debate, misses a little bit of the point on how are we going to sustain and grow primary care. I think that the infusion of dollars into primary care, mainly under the Medicare Advantage program, has really been a tremendous stimulus. As an example, this year, we'll invest north of $100 million in terms of local primary care, and we're seeing it sustain and grow for the long haul. But the second point I would make is that any sort of full risk program that's passing risk to an entity responsible for it, in this case, health plans, and in some cases, health plans to groups, needs to have a risk adjustment mechanism. Anytime you set out a program like that, I think there will be people that can abuse it. And I think there can be bad actors in any number of programs. I think the solution is better enforcement around that. I can tell you, we at Agilon, I'm really proud of the way we do it. It's a physician peer-reviewed process. Everything we do is tightening that relationship between the patient and the physician. We're not sending coders into homes to do capture of codes as an example. That's one of the things they talk about in their report. So I think it's a super important program. I think penetration in Medicare Advantage is set to go over 50%. And the last thing I'll say is I think there are administrative mechanisms that can make changes in benchmark rates and benchmark in terms of how that RAF gets calculated and captured and what's allowed within that program. And I think those are the vehicles that we should be looking at versus wholesale swapping out a program.
Thank you. The next thing I'd like to talk about has to do with the fact that you're one of several public companies that have entered into our sphere. By public, I mean publicly traded companies. Now, you're a CEO and a board member of such a company.
Yeah.
And as such, you have a very strong fiduciary duty to your shareholders to maintain and increase the value of the capital that they've invested into your company. And that's as it should be. That's a good thing.
Yeah.
Some people have criticized, however, the American model version of our business system by saying that its reliance on quarterly operating results and quarterly analyses of those results tends to generate a short-term focus on the part of its boards and on the part of its management to some extent. And, one would train for a series of sprints differently than one would train for a marathon.
Sure.
And when you're talking about something as important as healthcare, in which many people feel it should be considered more of a right than a commodity, that can lead to problems. That can lead to issues in lack of long-term execution. My questions are very brief. Do you feel that pressure? Is it real? And if so, how do you manage around it?
Yeah, I think it's a great question. I think that there's a lot of things we can do better in the healthcare system overall. I think short-termism is one of the challenges we've got. I'm not sure, John, that that's necessarily related to public, private, or profit, nonprofit. Think about what I talked about. We enter into 20-year joint ventures. We get married with these groups. We say we're going to do this together and make this move. Gives us the ability to invest well ahead of the outcome and take that holistic view, bring those resources in that are needed, allows us to take out a lot of the waste and excess, take the same dollars that were there, the same patients, the same physicians, and drive much better cost, quality, experience outcomes. So I think that we as a public company have been able to balance that. Do we have to have quarterly calls and report things? Yes, we do. But I think if you're really smart about how you manage that out, I think as you look at the people who've chosen to invest, because you do have investors when you're a public company, they understand where we're going. They understand kind of the long term and then what those milestones are along the way. But this is really about a new primary care model and changing things in a really meaningful way that the fragmented short-term system today with players in a lot of different places has not been able to address. So I don't see it as an issue being a public company to make that happen.
Thank you. Now let's talk about some real current events, very current as a matter of fact. The recent announcement of Amazon jumping into this somewhat crowded pool.
Yeah.
has certainly stirred some conversation going. Would you like to
You,
comment on that for briefly?
yeah,
And
you can,
I
you can say
emphasize
that.
and take your give us your share, your take on that.
Yeah, John, I think it's a meaningful announcement. I think it's another data point that reinforces that the healthcare industry is in the early stages of realigning around primary care. And that this need for a new primary care model that I've talked about is greater than ever. Amazon has disrupted a series of industries. And I think when they look at the primary care access model today in healthcare, they say the experience is pretty crummy. The access is very challenging. And there's been an underinvestment in technology and data. And so those are things that we've kind of agreed with for a long time since the company was founded. And this long-term view that I talked about, that's the view Amazon's going to take. They're a publicly traded company, but they're not going to take short-termism around this. They're going to be focused on how do I change that experience overall. They're in a very different part of the world than we're in. I sent a note to our partners today and to partners who are thinking about joining on saying, this just reinforces the opportunity, the chance to really transform your existing practice, everything you've been building, making that move from fee for service into this total care model gives you the opportunity. And let's make sure we're making those investments today that might yield results tomorrow or a day after. And so that's how I think about it. But I think about it as a real catalyst and kind of a call for some urgency around this new primary care model we've been talking about.
Would I be correct in saying it sounds like you view this almost as much of an opportunity as a threat to your company?
Absolutely. I think that virtually every part of the healthcare sector now looks at primary care as the vehicle for transforming healthcare in this country. Look at the topic of this summit that we're talking about right now. And so I do look at it that way. I also think that primary care physicians that a few years ago felt very beaten down and burned out, I've had so many say to me, it's fun to be a primary care physician. Again, I'm actually practicing medicine the way I was trained. And so as I've talked to you in other settings, I'm really optimistic and excited about where it's going.
Thank you very much. Okay, last real question, and then we'll just get into some chat about current events and other topics. But I want you to assume for a minute that I am the CEO of a 50-person, 50-provider, multi-specialty medical group in Los Angeles that has 8 clinical locations and is about 20 years old and has decided that it's time to move on to its next step and seek a strategic relationship with a larger partner. Yeah. And assume further that there are 4 candidates that have made the short list, and 2 of those are medical groups that are owned and operated by competing hospital systems in town. A third I won't identify on the program, but I'll just say it's a fairly aggressive consolidator of medical groups.
Sure.
Whose name begins with a vowel. And you guys are the 4th. All right, now it's your turn to address the board of this medical group. Tell me what 1 or 2 points that you think are very critical that you would like to have the board retain in this situation.
Yeah, no, I think the first point we would say is our mantra is the ability to keep the independents independent. What you've built over decades, what you've built in Southern California that you talked about, has incredible value. what brought you to this point are really based on the challenges of a fee-for-service system. And so we can give you lots of examples of other groups who've made this decision and found tremendous opportunity in what they've built with their patients, with their reputation, their knowledge of that local market. And together, we can really change the trajectory, and your group can be here 50 years from now and be much larger and be a leader in terms of driving integrated primary care forward. So that is really the main thing that we talk to people about, John. Now, the second point I make is typically we wouldn't be doing that in Southern California. We tend to go to markets in which this hasn't been done before. And this is almost like speaking a foreign language, and groups haven't really felt maybe it was possible to do that. And we need to go talk to 3 or 4 health plans who've never done it before and help them get there. In Southern California, there's a long laundry list of how that kind of happens. It's such a different model in California versus in other places. The rest of the country doesn't really look like that. So, but those would be the 2 things I call.
Thank you, which leads me to kind of the last question that will wrap up our 30-minute session. I wish we had 90 minutes more to continue the conversation, but the question is, I noticed that you have exited the California market.
Yeah.
And, that's kind of indicated because of the fact that the California market has developed these expertise. Can you briefly tell us why you did that?
Yeah, I mean, the headline is it's a strategy choice. The California market, Southern California in particular, Southern Florida, very different approach. They've been doing it for a long time. In those markets, typically health plans delegate many of the functions they traditionally do, like claims, customer service, utilization management, to the groups, and they execute those. That doesn't work in other parts of the country where the majority of people are and where the majority of opportunity sits. And so it was almost like operating 2 businesses. We had an MSO that we'd acquired in California, group was there. That didn't export to other parts of the country. We'd go to talk to other payers. They'd say, I can't delegate that to you. I need to continue to be the health plan, do all those functions. And so what I've found in organizations that really are successful in transforming industries and driving that change is they're very focused and pure. And so we made the decision to say, this doesn't fit. It was a relatively small part of our business. And you can see where we're at. 12 states, 25 communities, 500,000 senior patients, and 1% of the primary care physicians in the country. So I think it was a pretty good decision, and it's had some good outcomes.
Well, thank you for answering that, and thank you for all your time. In fact, I'm going to give you a bonus 45 seconds if you have any final thoughts that you'd like to share with us. If not, we really appreciate your valued expertise and your time in helping us to achieve the goals of this summit.
Absolutely, John. Well, one, I appreciate the opportunity and appreciate the conversation. I think this summit is really timely. I think that, as I said, we are at the early days of the healthcare industry really realigning around primary care. And how do we create that new model? I think sometimes in healthcare, we're too short term. I think we're too fragmented. And I think people realize at the end of the day, we're taking care of people, and primary care physicians are in the best position to do that. And so I'm excited about the opportunity that's going forward. I'm encouraged by more and more people recognizing that. And I think we're going to have a wonderful few days here in the summit as we talk about the best way to make that happen. So thanks for the opportunity and the conversation.
On that, we absolutely agree. And thank you one more time.
Amen. Thanks, John. Be well.
Thank you.